Well, again, thank you everybody for coming. My name is Dr. Makoui. I'm one of the neurosurgeons. I do brain surgeries and spine surgeries. We are hopefully going to get one of these sessions for spine evaluation also. But this is the most critical part because most people are not familiar with how to evaluate a neurosurgery patient, a brain surgery patients. Both before surgery, how do we need to keep this patient alive? Like we have somebody right now in ICU 7, that is gonna have a lady with a big brain tumor, I can show you, and is gonna have surgery tomorrow. She has a lot of edema, she had a cardiac event this morning. So we need to do right things to keep her alive until we get her to OR, but then after the surgery, it's important to know all the bad thing and all the wrong thing that can happen to this patient, so sort of like be on top of it before the actual thing happens. So I had some back pain myself. I'm opening my back brace, and then we're just gonna go and start here. Okay, so in a post-op craniotomy patient, the evaluation and assessment that you get right after the surgery, when the patient rolls into the recovery room, that's the most important one. That's the baseline that everything else you'll be comparing to that. Obviously, initially it's limited by the fact that the patient is sleepy from anesthesia and the narcotics and all that given, but you wait until that patient wakes up, and the first assessment by the PACU nurse, which should be done with the anesthesiologist, and the surgeon, so everybody is on the same page, is a very important one. You wait until meds wear off, and that's going to be, so if you have a patient that is like half an hour you're waiting and is not waking up, and you give a reversal of whatever narcotics and it's not waking up, a red flag should be going ding, 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 something may be wrong. There may be a bleed, there may be something has happened, so that patient needs a right away scan in the recovery room I'm talking about. So the first thing in a neuro exam and evaluation is the level of consciousness. How awake is this patient? So when that's ICU patient, let's say you're walking even from far away, that's something that you can assess immediately, even without talking to the patient. That is this patient is like a comatose, or is this patient awake, alert, following commands appropriately, or the patient is sort of awake but thrashing around purposelessly, confused and all that. So the level of consciousness, which is, is the patient awake, does he, she follow commands and all that. If there is some disturbing sign about the level of consciousness, you gotta first quickly ask yourself the obvious question. Was a medication given, because that's the number one cause that can cause this. Don't assume that the brain has something wrong with it right away, because the number one cause of decreased or diminished or change of level of consciousness is medications. Top of the list is obviously narcotics, benzodiazepines and all that, and then if that's not the case, then the second thing that you got to think about is hypoxia. Is the oxygenation good or not? These are the two most common, Then the third most common cause that would be altering, especially in older people, in frail, debilitated older patients. The third is infection, an unknown infection. So a UTI or a pneumonia, all these nursing home patients, they come, they're confused, they're thrashing around, or they're difficult to arouse. So technically it's a change of level of consciousness, but it may all be caused by a UTI or a pneumonia. So infection, hypoxia, and the number one, meds. These three are the main things that can be altering the level of consciousness. Okay, so the next thing is that you want to evaluate this patient. Let's say this is a post-craniotomy patient, or with some brain pathology, could be tumor, could be hemorrhage, could be mass, edema, anything. So if you've assessed the level of consciousness, the next thing is just go straight to the size of the pupils. Those are the most critical. See if they are reactive to light, so darken the room, allow the pupils to dilate when you darken the room. And then you flash light, shine the light one side, the other side, see if the side that you shine contracts, see the other side contracts, and then do the cross-checking, which is you shine in this one and see if this one contracts, you know? So, and then if it contracts, look at the note of, you know, that is it contracting all the way down, or is it just a tiny bit contracting, you know? Or is it just dilated and fixed pupil, which is a bad sign, you know? So all this may be telling you a lot of things about intracranial pressure and the pressure on the third cranial nerve, which controls the size of the pupil. That's what you're trying to get at. When you check at the size of the pupils, you are thinking in your head, is there a mass or is there increased intracranial pressure that is affecting and causing the third cranial nerve, which controls the size of the pupil? That's where you're trying to get at, you know? When before there was no CT or MRIs, that was a very important thing. And then a motor exam, a quick motor exam by simple thing. Is the patient moving right side, left side, arm, leg, you know, and see if it's done purposefully, or is it just haphazardly and unpurposefully, you know? If you tell the patient, squeeze my hand, right side, left side, wiggle your toes, right side, left side, hold up 2 fingers, wiggle your thumb, stick out your tongue, you know, these are all simple commands that tells you a lot. Tells about the mentation and comprehension of the patient, but also tells you about the motor system, because if they're paralyzed in one side, they're not gonna be able to do that, okay? So simple things, and write these little tricks and things that I'm telling you, because at the moment you can't remember what to say, what to do and all that, but you have a list of 4 or 5 things that you always do. It becomes automatic, like, you know, you don't have to think about how am I gonna check this, how am I gonna, you know. So first level of consciousness, then pupils, then asking the patient to do things, and by that you're assessing the right side, the left side, the upper, the lower. Also you're assessing the comprehension of the patient, the language of the patient, you know. If for example, you tell me, go take your bottle and open the cap, okay? Obviously you're checking my motor system, I'm doing all these things, but a lot more is going to that. You're checking my speech comprehension, you're checking my cognition, you know, and you're checking my judgment and execution plan. So a lot of systems are checked by that simple thing, you know, following that simple command. So, okay. I mentioned that following commands is you say, squeeze my hand, right side, left side, wiggle your toes, show me 2 fingers, you know, hold up 2 fingers, or wiggle your thumb, left side, right side, stick out your tongue, you know. These are simple tricks, so what you can do is just keep this in the back of your mind. So then, the most critical point is to quickly recognize any new change in a neuro exam, okay, as compared to baseline. So if something bad is happening to this patient, but you don't even recognize it, then you'll never pick up the phone and you'll never escalate it to the next level and next level and next level. So the whole thing dies right there and then. So major disaster could be brewing in patient's head, but if you don't pick it up, because the doctor is not there all the time, you know, you're there. And that's why it's so important to recognizing. And the way to recognize is by doing these little tricks that I'm showing you guys, okay? So you gotta have a good baseline first, and then you compare those subsequent exams, if it's a Q1 hour, Q2 hour, Q4 hours, whatever, to your baseline exam. And if there's a change, that's where you pick up the phone and call. Now, this means that when the patient rolls in from the operating room, and here I'm a PACU nurse, I want to do wait for a little bit for the anesthesia to wear off. I want to do the first exam with the anesthesiologist or the surgeon, you know, who has seen the baseline exam of this patient before. So that baseline exam is very important. Now, imagine you are ICU nurse, the patient arrives, okay, the patient is getting transferred and you're accepting this patient from the circulating nurse or the PACU nurse, okay? Or you're in the next shift, you're coming 7 p.m. and somebody has been taking care of this patient in ICU all day long, and you're the accepting person. The best thing that I always suggest is take up your phone, take a video, 1-2 minute video with your phone of the neuro exam of this patient with the person who is handing you this, okay? Simple things. Hi, Mrs. So-and-so, see if she's awake, She follows command. She moves right side and left side symmetrically. Tell her to do a couple of things. Hold up 2 fingers, wiggle your toes, So this is a critical thing. Why? Because it also tells you throughout your next 8 to 12 hours you're dealing with this patient. If something goes wrong, you say, oh, this doesn't look like how I got her or got him. That's one thing. And second thing is you have a baseline that you can communicate, and if something has happened that was bad, it was not noticed before, you don't end up taking the blame for it, So that's why when you accept a new patient, do a quick neuro check exam as a baseline with the person that's handing it to you. And the best way is now in this day and age is 1 minute video, So go through this 3 or 4 lists of quick things, tell them to do while you're videoing. Do not delay or hesitate about calling immediately. What's the worst thing that can happen? That it was you panicked and you called and there was no need for calling. No big deal. Nothing has happened. I have my phone, which is available, cell phone. You don't have to go through answering service, this and that, 24/7 next to my ear, So any questions, any ambiguity, any worry, any concern, you just give a call and sort of bounce it off me so I can guide you and tell you this is okay or no, this may be some problem, let's get a stat CT. But if you don't make that call, if you don't recognize that abnormality, or if you recognize it but you're shy, don't want to call, then everything goes down now. Yeah, please.
I would like to suggest that if you're ever in doubt and you're not sure, to of course 100% call him. But Dr. Makoui is great about calling throughout the night to check on the patients, but also he will get on FaceTime with the iPads.
Yes.
So that way he can physically put eyes on the patient.
Exactly, and that's the last time we mentioned this, and that's a very good point. Thank you for reminding us again. Now that we have all this technology, you get the iPad. If you don't know what you're seeing, show it to me. Takes the responsibility off you, puts it on me, or get a video of the patient, text it to me. Say this is what's happening. If the iPad is not working, your phone. Now with this, if the CT scan is done and I don't have access to it, please take a video of the CT scan, scroll up and down, text it to me and call me. So it is incredibly more valuable if you call me 2 or 3 times excessively, which may have not been necessary, versus you don't call me and then disaster happens. I'm going to give you an example of that. One real example from our own ICU, because that's a lot of learning in that case. So when you receive the patient in PACU, that's what I said, get a baseline neuro exam. I mentioned that, so pay 100% attention to the parameters that's set forth. Whether it's head of the bed or whether it's blood pressure. Blood pressure is a very important one. Why? Because in the first 24 hours, especially the first 16, 18 hours after surgery, these vessels in the brain, the whole brain has been under stress because of all the adrenaline, noradrenaline, the whole body, but especially the brain. And the vessels, if those are fragile vessels and tiny, puny vessels, because of the stress of the surgery and trauma and the pathology and all that, those vessels can rupture. Those tiny little micro vessels inside the tissue of the brain. So when we say keep this blood pressure below this, for example, the example of the patient that I'm going to show you, we had that the patient's systolic blood pressure. This is a